and they end up in the emergency room. And this can happen over and over again. So that can be taken care of while the person is home, because this interdisciplinary team, nurse, doctor, social worker, are able to actually come and help that person in the home. They can prescribe medications, they can give them an ID, they can help connect them to support services, to other therapies. They don't have to end up back in the emergency room and have to go through a whole workup again. So that's a benefit. That's just one example of how community-based palliative care can be helpful. Or does somebody ask something? I can't hear you.
Did you say IP?
IV.
IV, yes, a person can have IV in the home. Is that what you asked? They could have IV in the home. Some of the other reasons why palliative care might be desired and helpful is if a person has a lot of different physicians that they go to. As we get older, we have different types of things going on. We end up having a lot of doctors. It actually becomes talk in the grocery store. Oh, which doctors are you going to today? You know, it's a thing. And then when you think about all the medicines that you have for the different things that you're going to doctors for, it gets a little bit confusing. And if there's not one conductor who's overseeing that orchestra and who's really looking at all the medicines and managing those medications, you could have issues where one medication can be contraindicated to another, and it's not always known. Sometimes if you get forgetful, I also get forgetful. I just saw a great cartoon. I put it on my door at the office. It says, "What do we want? Better memory. When do we want it? Want what?" And I have to tell you, that happens to me. I come home, I walk upstairs, I forget what I went upstairs for, and I go back down. And, you know, it's an unfortunate reality. We have so much going on in our lives. We're like, you know, overloaded with information. We're overscheduled, whatever, family stuff, whatever it is. But the concern is that sometimes people forget to take their medications. Sometimes they end up taking it twice because they don't remember they took it. So sometimes there's a medication that a doctor will pull because it didn't have a good result. And if the pharmacist doesn't know that and it's on an automatic refill, there's a lot of medication errors, is my point. So again, this is one of the ways that a palliative care consult or community-based home visiting service can be helpful. Also, goals of care discussions become very important. So if somebody is seeing a lot of doctors and they have a lot of things going on, somebody needs to take the lead and say, well, what are your goals of care? It's a very important conversation, so that you really are working towards a care plan that makes sense based on what you want, and not just on what the doctor is trying to fix. And lastly, people that have a rapid or dramatic weight loss over a short period of time, that's another indication that you might want to have a palliative care consult. So how do we screen for palliative care? Well, there's an inclusion criteria and there's exclusion criteria, like everything in life. It could be on the in-group, the out-group. The inclusion criteria are that a person has a life-limiting illness with evidence of distressing symptoms. The patient's physician agrees that this is a good thing, and the patient, him or herself, wants it. Those are the inclusion criteria. The exclusion criteria is that a person needs counseling in the absence of illness, or a person has psychiatric issues in the absence of an illness, or just a lack of active symptoms. You know, it's not just like having an extra piece of jewelry. You know, it's not just an extra thing. It's if you need it. Everyone under the Medicare benefit, I'm assuming that everyone in this room, almost everyone in this room, if they are old enough for Medicare, has accessed it. Everyone is entitled to a one-time consult for palliative care, at which point they will do an assessment. If it was a person who's very ill with advanced illness, it would also be an assessment for hospice, if that's something that is appropriate. But how does it work in practice? So now somebody's on community-based palliative care. So then what? Well, there's an initial consultation with follow-up visits for a 60-day period. There's a lot of telephonic support. If a person needs to continue on palliative care, so different than hospice. Palliative care, you're getting it for as long as you have that symptom burden. If it's resolved, if it's managed, you would discharge off of palliative care. Let's say a person is not appropriate for palliative care, but they do have some sort of life-limiting illness, but they don't have any active symptoms. They can continue to be called back to see how they're doing, but they're not going to get those home visits. Visits are made, and case coordination is made through the members of the interdisciplinary team. The nurse practitioner and the doc can write prescriptions. The medical social worker can offer psychosocial counseling. And they also help with getting other kinds of therapies and assisted services in the house. So that's really what palliative care is. Okay, you don't have to have an end-of-life diagnosis or prognosis. You can still continue to do everything else that you're doing. You're getting 3 types of disciplines in that interdisciplinary team, but you're not getting all of the things, the basket of services that somebody would typically get when they're on hospice. So now let me try to explain to you what hospice is. And I'm going to repeat something I said earlier, which is that all hospice is palliative care, but not all palliative care is hospice. Hospice is a special kind of palliative care when somebody is really in the terminal phase of their illness. So, there's an organization. That organization's name is NHPCO, the National Hospice and Palliative Care Organization. And they monitor, they gather data from all people who have had hospice in the country. They measure patient satisfaction rates and so forth. And they put out percentages and statistics. And the continuous feedback from NHPCO in family satisfaction surveys is, I wish we had known about hospice earlier. And I can tell you from firsthand experience as a primary caregiver for 2 parents, one that passed away in 81, 33 years ago, and one that passed away 16 years ago, that we had a horrible, horrible passing from my father 33 years ago. Such a horrible passing that it still gives me the chills today to think about it. Horrible. And my mom had a beautiful passing, whatever that means. But
You're in the right one, Lucky?
Not this one, no.
Oh, sorry.
Thanks for coming.
Sorry.
my mother had hospice. I didn't know what hospice was. When the doctor said, you know what, Toby, you should look into hospice, I wanted to kill him. I really did. I was like, you're going to give up on my mother now? You're the doctor that we trusted. My mother loves you. She calls you the actor because you're so handsome. You want to give up on her? I was so angry. But of course, I didn't know what hospice was. To me, it was the Grim Reaper, with a sickle and a hood. And I am a child of Holocaust survivor, so for me, to give up on somebody like my mother, who was everything to me, was not part of my reality at that time. Not only that, she was living in a different state. So he said, she's not going to be able to take care of herself. And I said, well, what do you want me to do? Handcuff her and bring her to New York? He said, when she can't do it anymore, she's not going to fight you. And so it was. And we brought her to Queens, and my entire family cared for her. But he was not a prophet. No doctor is a prophet. No mortal being is a prophet. He told us that she wouldn't make it through the summer, and she lived for another 10 months. And we did eventually put her onto hospice. Again, I didn't know what it was. Really felt like I was walking off of a cliff. And what I realized after she passed away was that it was unbelievable. It was really unbelievable. Because we were so close, and my family cared for her, and the hospice team came in, we had our finger on the pulse of any change. We were lucky she allowed us to help her and care for her. She was a loving person. She was that kind of a person. Not everybody lets you care for them, right? My father was the opposite. So it was really quite something. But after she passed away, what I realized was, not in the moment, it was a few months later, I realized that there was something missing from the experience. What I realized was there was absolutely not an iota, not a shred of anything spiritual in her care. And that was really, you asked me what I do, Mark, and it was really at that point that I made a very conscious decision that I was going to find a way to give back. And if there was a hospice that had any Jewish component, I was going to find out about it. And quite by accident, I saw a flyer and a poster in my community where I live about a meeting that was going to take place, and it was about a Jewish hospice. I was invited to join the advisory board, and I sat on that advisory board for Metropolitan Jewish Health System from 2005 to 1998 till 2005. My background is I have a master's in human resources management and a master's in organizational development. So I do career in organizational development. I have practiced for over 20 years. And corporate areas of my expertise were in the hospital and health system industries. And after 7 years of voluntarily giving myself to this organization, I got an email, random, although is there anything that's random in the world? And I got an email that they were looking for a project manager for a grant-funded program that was being funded by UJA Federation of New York. And the name of that grant project was Increasing Access to Palliative Care for the Orthodox Jewish Community. So I didn't look for it. It looked for me. And I figured since my goal was to give back, I could take 1 year of my private practice and my livelihood and do it part-time and do this project work part-time. So when I emailed back and said, I don't know if you're interested in a part-time person who you'll get full-time work from, because if you're a consultant, time is money. So if I work, I'm working, I'm producing. I said, if you're willing to entertain that, I'm really very interested in finding out more about what this is. And the rest is history. And I work with them full-time now, and I do my career counseling and coaching part-time. And that's really how I got into this work. So now let me tell you about what the changes in hospice are. What is hospice? And that's really what I want you to know. So this graph that you see up here, let me try to explain it to you. So when should hospice be introduced? So if you see on the left-hand side of the graph, it says diagnosis of serious illness, right over here.
Right.
Yes? So from the time that a person receives a diagnosis of having any kind of an illness, serious illness, it's at that point that palliative care should be and could be introduced. Why? Let's say somebody's undergoing chemotherapy. They're going to Sloan. They have a diagnosis. They have some sort of malignancy, and they're going to beat it, and they're going to treat it so that it could be cured. They could be in remission, and whatever they're going to do, they're going to do. But guess what? What happens when a person's on chemo or radiation treatments? They have side effects, right? Those side effects are terrible. Fatigue, pain, nausea. They can't eat. They can't sleep. They get burning on their tongues. They're putting poison in a person's body. But they're going to beat the cancer because they caught it at the right time. And it's treatable. But they have side effects. Well, they could be getting palliative care alongside whatever else they're doing. Let's say it's not a disease like cancer, which has a terminal end. let's say a person has some sort of a chronic disease. Let's say they have CHF, congestive heart failure. A person could live with congestive heart failure for many, many years, right? But let's say they're very short of breath and they're having an episode. And they're going to do whatever they would normally do. But they could also have palliative care. So, from the time of diagnosis, they can continue to get life-prolonging therapy, their treatments, alongside, but to a much lesser degree, right? Because the wide part, the green part, is the life-prolonging therapy, and the palliative care is little, right? It's small. But as the disease progresses, they're getting more palliative care, lesser on the curative side, until it gets to the point where it peaks, and that's where they can no longer treat for cure, and they are at an end stage, and at that point, they would then be eligible or appropriate for hospice consideration. And on hospice, it's all palliative care. You're not curing, but you are aggressively managing pain and symptoms so that you can have the highest quality of life possible for as long as possible. So what are the hospice eligibility criteria? I already mentioned this to you, so for the sake of time, I'm not going to repeat it. It's really just a 6-month diagnosis by 2 physicians and no longer seeking to cure. And what are the types of diseases that have end stages that are typically disease progressions that would end up with a terminal phase? You'd have cancer, COPD, like pulmonary disease. You might have strokes, Alzheimer's, liver disease, ALS, cardiac disease, renal failure, AIDS, and there's other diseases as well. Even mental disabilities at some point can turn into some sort of a chronic or severe illness. There's comorbidities. There's any number of diseases. So what do we offer? Again, I'm telling you what we offer at MJHS, but realize that most hospices also offer most of these services. You have a hospice medical director who's a pain and palliative medicine physician. There's an RN case manager. A lot of people don't realize that, so I want you to know this. The RN, the nurse, has a very important role. The nurse is really the person who coordinates the care. So there's a whole team of people. These 2 columns of bullets talk about the different kinds of comprehensive benefits that a person is entitled to when they have this care option called hospice. But it's the nurse case manager who is the conductor of the orchestra. She's the one who's coordinating all the care. Every other week, they have interdisciplinary team meetings every week, but every other week they go over every single person. Within 2 weeks, every case is reviewed, unless there's a change and you have to go over it earlier. It's the RN case manager who's the point person. If the person has a problem, you call the RN case manager. RN case manager is the one who coordinates everything. There are medical social workers for case management, discharge planning, and supportive counseling. All 3 of those disciplines are generally, well, all the physicians and all the nurses must be, at least in our hospice, must be board certified in pain and palliative medicine, pain and palliative nursing. And the social workers also have to get certified in end-of-life care. We have music therapists, we have creative art therapists, especially with the Alzheimer's patients or different types of dementia. The music therapy is extremely soothing. Anyone could get it, but we find an unbelievable benefit with people who have memory loss. There's a spiritual component. There are pastoral care providers that are all compatible, dependent, and consistent with the patient or family's belief systems. They function pastorally. If in certain families, the patient and the family is connected to their own faith leader. If it's a Jewish family, they'll have their own rabbi. If it's a different faith, they're connected to their own faith leader. They may not want the chaplain to come into their house and to function pastorally. So what we do in those scenarios is the pastoral care provider wears a dual hat. So either he's going in or she's going in to be a chaplain and serve them spiritually and pastorally. If they don't want that, then they function dually as a liaison. So what do I mean by that? Well, a lot of times a family member will open up to a non-clinical person, what they perceive to be a non-clinical person, in a different way. And the pastoral care providers, whether the family realizes it or not, have a whole toolbox of skills that they use that help a person, even if it's not about their religion, but there's life reconciliation. There's a lot of things that come up, and they will then be a trigger. They will connect so that the faith leader that they have in their own community and the hospice medical director can speak directly about goals of care and care planning decisions. We have an Art and Soul program. A lot of times children are very close to the family member that is ill, and we have a very bad habit of not talking to children about stuff that's going on when people are very ill and dying, but the children feel it. So we have this Art and Soul program where creative art therapists will go in and speak and meet with children, and through art allow the children to express themselves.
It's wonderful.
It's beautiful. It's a beautiful thing. And I'll tell you something really special. Something very special is one of our creative art therapists was going to visit a child. I also didn't tell you, I should tell you, we actually have a pediatric hospice program. But I'll tell you, it's just, I wish that we would be put out of business, really, but we'll talk more about that in a little bit. So this fellow, his name is Matthew, was going to visit this child, and there was a postman who saw him making these visits to this child's house and said to him, "What are you doing?" Now, Matthew is physically disabled, so he walks with a cane, and he said, "What are you doing here?" I just saw him. And he explained that he was there as a creative art therapist, and this postman, there's a group within the Postal Service. They're called the Better Angels. And what they did was, he was so taken with what Matthew was doing that he got his group of postal workers and they collected $10,000 and they donated it. And we developed something called a legacy kit. And it's a canvas bag that has a CD of music, of songs that the music therapist composed and sung. It has a memory book, so it's a picture frame that opens up, and the children can put pictures of their family members in it. It has a journal, it has maracas, and it has puppets. And this thing is called the Legacy Kit. And we were able to produce them and use them with children. It's quite outstanding. This is something that the postal workers donated, and now our foundation then kicks into. We have home health aides. When you're on hospice, part of the routine benefit is that you get a home health aide, 4 hours a day. There are volunteers. Everybody is entitled to have a volunteer. In fact, I mentioned to Mark before this program started that we're always looking for mature volunteers. And if anyone in this room feels that they themselves or know anyone that might be interested in being a volunteer for us, we would love to have you. And I can tell you more about that.
What do they do? What would they do?
So, the volunteers actually become part of the clinical team. They are a member of the clinical team. You have to commit to being a volunteer for a year. You could continue more than a year, but we need a commitment of a year. And you have to commit to 3 to 4 hours a week. Travel time is included. We have a large census. We see a lot of patients in Manhattan. So if you're all from Manhattan, that's not a problem. And you just do different things. It could be friendly visits. Sometimes people don't feel comfortable being with people who are dying. They might say, well, I used to be a librarian. or I used to do whatever. I would love to be able to do that to help. Or you could do errands. You could walk with the patient. You could just be a friendly visitor. It could be any of that. We have a very intense volunteer orientation. It's 8 to 12 hours. We could bring a training to a place if there's a group. Otherwise, we have you come to us. Volunteers are really very important to us. It's actually one of the Medicare required regulations. 5% of the patient visit hours need to be with volunteers. So you really do become part of that interdisciplinary team. You're invited to participate in team meetings. We even have a volunteer week. And that's, I could tell you more, but that's, I didn't tell you a very important thing. Volunteers have to go through not only orientation, but employee health and reference checks and criminal checks, just like doctors when they work in hospitals. Anyone that works in a hospital has to do the same thing. It's all part of it. And the reason that they insist on commitments of a year is because it costs us a lot of money to invest in the orientation and the reference checks and all of that stuff. So that's what the volunteers do. So now let me tell you, let's go back and let me tell you more about the levels of care. This is a very, very important piece of information for you to know. People mistakenly believe hospice is a place. If you ask most people, they don't really know how to describe or understand what hospice is. Hospice is not a place. Hospice is a kind of care. I told you what the criteria are to be eligible for hospice, but there's 4 different levels of care that go along with hospice. Now, hospice can be provided in different care settings. Hospice can be delivered in a hospice residence. We have 2 hospice residences. One is called the Block Residence. One is called the Zicklin Residence. They're both beautiful. They're like efficiency hotels. That's what they look like. They're beautiful, outstanding. It could be in an assisted living center. It could be in your apartment, in your child's home, in your home. Wherever it is that you live, that's where hospice can be delivered. And that would be for the routine hospice benefit, for the home hospice. Most hospice is delivered at home, wherever a person lives. But then the benefits you get are all the things that I just described in the previous slide. But what happens if a person has a higher acuity level of care need? They're having symptoms that are not effectively being managed at home with their routine hospice benefit. They're having a critical event. Their shortness of breath is really uncontrollable even with the oxygen. Or the pain is not being managed even with the pain medications. And nobody should be in pain today because we have enough drugs in the world to find the right cocktail that does it for each person differently. So when a person has this higher acuity level of care need, they would then be eligible for something called general inpatient care. We call it an IPU level of care, inpatient unit level of care. Inpatient units are in different places. We have a few inpatient units where you have people around the clock. It's hospital-like, but it's not a hospital. We have inpatient units in hospitals, like at Beth Israel Hospital, we have an inpatient unit. At Roosevelt, St. Luke's Roosevelt, different places. In nursing homes, we contract with nursing homes, 58 nursing homes. We can provide inpatient level of care in some of those nursing homes. But the point is that if a person has a higher acuity level of care need that is not effectively being managed well at home, they can go to an inpatient unit environment until those symptoms are managed, and then they go back home. The other way people use an inpatient unit is if they're being discharged from a hospital. So I think everybody knows in today's world, even if you're not in healthcare, that there's this issue with hospitals where they continually try to reduce what they call length of stay. You can only be in a hospital for a certain length of time before they say, you're really not benefiting from what we offer you in the hospital, and we need to do a discharge plan with you. And of course, the family and the patient feels they're throwing me out. Whether that is true or it's not true, that's not what I'm trying to talk about. What I'm trying to talk about is sometimes when the hospital says, we can't keep you anymore, we have to do a discharge plan, and that person is hospice appropriate, and they're going to be evaluated for hospice. But even with going on hospice, there are still some symptoms that need to be managed before they can take that next step to go home. They can be discharged from the hospital to the inpatient unit till those pain and symptoms are managed, and then they go home. So that's inpatient level of care. Sometimes it's also for end-of-life care. But what happens if a person is at home and they're getting hospice services at home, and they have a critical event where they have really these higher acuity level of care needs, but they don't want to leave the home? Well, then you have another level of care, and that is called continuous care. Continuous care brings that higher level of care into the home by giving the person 8 to 12 hours a day of a home health aide and 12 hours a day of a licensed practical nurse. And that remains in place for as long as it is clinically needed. So it will be reevaluated every few days because of the cost of that care and the very stringent regulations from the Department of Health. We're not going to do anything illegal. So the continuous care will remain there. So what are some of the things what would that look like? If a person's pain is not managed, they really just have to have a nurse administer treatment, that would be one of the reasons. If a person was needing assistance because they were so dizzy and so agitated that they really needed more close monitoring, that would be a reason. It's different reasons. So as long as it's needed, it's there, but then it stops. Continuous care is not a long-term program. The last level of care is something called respite care. Respite care is for the caregiver. Let's say you have a family member that you're caring for, but you have to go out of town for business, for a family function, vacation, or whatever. For whatever reason, you're leaving town, but you cannot leave your family member without you. Well, then that family member who's on hospice can be moved to a nursing home on the hospice benefit. They don't revoke. They're still on hospice. But they can stay in the nursing home while you're away, and when you come back, or when you have your respite, when you have been replenished, they come home. So the respite benefit allows that patient to be in the nursing home setting for 3, 4, 5 days, and then they would come home. And those are the levels of care.
How often are they allowed?
So there's a certain number of times a year. I think I don't know the number. It's not every week, you know.
That's overnight or 180 days, right?
Something. I don't want to misspeak. I'd rather say I don't know and I can find out than to say something that I don't know. So what are some of the I'm just looking. We're really almost done. There are different levels of frequency for how often the different disciplines come to visit. The RN case manager comes at least once a week or as needed.